So, ladies and gentlemen, I'm very happy to see all these faces here. Believe it or not, we're starting the last day of our session in Bio Lounge. And I'm pleased to welcome our first speaker in our global clinic, Marcus Ang, who flew from Singapore.
Thank you. Thanks very much. All right, thanks very much for coming, having your lunch, choosing to have your lunch here. So a little bit about myself. Thanks very much to Marie and the YO committee. Congratulations on such a great lounge and great YO events. So a little bit about myself. I come from Singapore. I'm a cornea and refractive surgeon. I'm based in Singapore National Eye Centre, which is the largest eye centre in Asia or around Asia. I did my fellowship at Morpheus London. That's a long time ago. And I've been invited to share a little bit about the work that we do in Singapore. So we have an NGO that's based in Singapore. We're basically a group of volunteers that work around Asia. And the name of our company is actually called Global Clinic. And also at the end, I'll share how, if our friends from Europe want to participate and join us, I'll share how we can do that. So this is a picture of the Himalayas, and that's where a lot of our work started out from. But really, who are we? We basically are an NGO that's based in Singapore. We registered officially in 2010, but it was actually founded in the 1990s. So we're not just an eye team. We also have women's health, general surgeons in that team as well. But I founded the vision team, and we just got registered with IPB. If you don't know, IPB is the Agency for Prevention of Blindness, and we work closely with WHO to develop programs as well as advocacy for ophthalmology. So what we do essentially, in a nutshell, is that we create sustainable health programs, where we try and plan sustainable health programs, not just in ophthalmology, but in various areas. And we go to developing countries. Most of our work is basically in Southeast Asia, as you can see, but also we go to China, India, and the furthest we've gone is basically Africa. So I'm just going to share three main aspects on what we do and how ophthalmologists and optometrists work together in these projects. So one major arm of what we do is outreach programs. Most of our outreach programs are currently in Southeast Asia, like you see, India, Cambodia, Myanmar, Indonesia, Thailand, and in Vietnam. And they're based on 4 pillars. So we have a primary eye care team. These are basically made up of junior doctors or young consultants, young ophthalmologists like ourselves, and partnering with optometrists. So they go out to remote areas, and we basically provide eye screening and eye evaluations, especially in areas where there isn't access. We also provide education. So we train local surgeons when we go there, or when we join them, and we teach them transfer skills. And of course, we also bring a little bit of a tertiary care. We bring surgical teams setting up in hospitals in rural areas. So that's kind of like the main pillars of what we do. And just to give you an example, we started in 2006 on the Indian side of Himalayas. So as you know, Himalayas has multiple sections, and Ladakh is the state which overlaps with India. And so basically just showing you some photos of the programs that we have. Usually we set up in schools or in tents or in abandoned hospitals. And basically, we usually see thousands of patients at a go. We also have optometry programs. For example, in this particular project, we actually trained for optometrists and school nurses. We actually sent them to India in LV Prasad, got them certified, and then send them back. So actually, I don't go back to the Himalayas anymore, because now there's an independent optometry clinic there, which is self-sustainable, and they charge patients, $1 or $2 per visit, and we don't go back anymore. Once in a while, we still go back to do camps. So surgical access to cataract surgery is absolutely impossible in the Himalayas, and there are some surgeons there, but they are very, very limited. And these are projects that we've been doing since 2006. The second aspect, like I mentioned before, is education, and we take this very seriously because it's one of our sustainable goals. I mean, it's no point us going in if we don't teach the nurses, the primary eye care practitioners how to carry on. And one of our biggest projects in terms of education is in Cambodia. So we've been doing this since 2009. It's about 10 years now. And basically what we do is we focus on training. So in Cambodia, the premise of most of their health care is taken care of by school nurses and health centers in the community. And so what we do is that we teach them how to do eye screening, evaluate children, as well as look out for primary eye care issues. One thing that we started doing recently as an NGO is measuring impact. So, for example, in Myanmar, which is our most recent program, we started in 2014. And by now, most of our teams have gone around and treated about 10,000 patients. But the difference is that now we are starting to try to report our outcomes. So as you know, cataract surgery and follow-up is very challenging, and a lot of data is not captured. So for example, my first trip to Myanmar, I didn't know this, but actually in Myanmar, most of them have genetically, because of genetics, they have very short axial lengths. So most of them are like 19 or 20. So I brought together like 1,000 lenses with a Singapore nomogram. And by the first day, I finished all my IOLs, because basically I needed 25 and above diopters, but all my IOLs were like 20. And so it was a hard learning experience for me. But there really, if you look at it, there's no census data. So what we're trying to do is to work with the ministry to provide feedback on the census, what's the prevalence of cataract, blindness, and their CSR rates are really one of the lowest in the world right now. And also, this is a great paper that was, I think, published in Lancet Health, which shows that early follow-up it correlates very closely with like long-term follow-up as well. So what we're trying to do is to collect the same amount of data. And I think we presented this at the American Academy a couple of years ago. And now we are now having like about 4 or 5 year data from Myanmar, which is very useful for their health planning and how much resources they need from a ministry's point of view. So this is a hospital that we set up. So this year, for example, we're going back to a different area, working together with the local ministry to identify areas where the CSR or the cataract surgical rates are very low and help out with their reporting. So just some photos of other countries that we go to, including Laos, Indonesia, and so on and so forth. So if you're interested in volunteering with us, this is our website, and you can let me know. It's a long trip to Asia, but most of my friends come and join me in Singapore for a few days. It's a great place to like have a few days of holiday, and then you can go on to like Indonesia for these camps. I must say that for our NGO, because we are registered with IPB and we have a very strong reputation, we do require a lot of medical certification and show that you are certified as an ophthalmologist, blah, 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 or what kind of skills that you have. But certainly we do encourage and invite our friends to join us from far, far away. And if you're still here, last but not least, we're having a YO meeting because all of us are here. I will share this with you guys soon enough. But we're going to have a YO meeting in January next year, so I invite all of you to join us. It will be just like you guys, will be a global focus. And January is a good time to visit. The weather is just like this. Actually, the weather is just like this in Singapore all year. But in January, it will be cold for you guys. So it would be nice, you guys want to come, jump into the pool, and then have a symposium. I invite you to join us. And if you want like speaking positions, you just have to email me and ask. All right. So that's my section. Very quick one. I'll hand over to my next speaker. Maybe Jaya first? Yeah.
Thank you. Thank you very much. I don't know if you want to take some questions whilst I'm setting up, or if anyone has any exciting questions for Marcus. Feel free to speak up.
Is that it? No. Yeah, any questions? So, guess not.
So some of the European countries, they are ophthalmologists, but they don't have the skills in surgery. They can bring some value in the organization, or it will be very difficult to.
No, yeah, absolutely. No. So most of the work that I show, only the surgical camps are just one aspect of the work that we do, and I would say majority of our work is mainly in running the primary eye care clinics or doing outreach programs or education. For example, we have an education program in Myanmar right now, and basically what happens is that I had to train their eye bank. So the first time I went to Myanmar's Yangon's Eye Bank in 2014, it's like they open up a fridge and there's like 10 donors and they go like, so which one do you want to use? And I'll be like, well, and there's no specular. So 1 year we had to go and teach the technicians how to use specular microscopy, teach the nurses how to prepare the donors, or teach the surgeons how to harvest donors and things like that. So there's a lot of educational value that volunteers can bring, depending on your skill set. And that's just one example, even basic things like using the Goldman tonometer properly is a huge issue in some of these hospitals. So basic stuff, the surgical stuff, that's the sexy part that we kind of like show people and stuff. But in reality, I mean, most of the groundwork is, basic stuff. Sure.
So I have one question as well. How do you do about funding?
Okay, so because we're a registered NGO, we do most of our fundraising in Singapore. We're a relatively cheap NGO to run, so our overheads are not very, very high. But we are fortunate enough to basically have funding from a lot of banks recently, and we also have a lot of businesses which support us locally, and that keeps us sustainable for a while. Yeah. Hooray. So the other unique thing about our NGO, just if you're wondering, is that, unlike other NGOs which have a pay salary or have staff or costs, one of the things is that all our donations go 100%, well, 99% to the patients. So all the volunteers pay their own way. In fact, a lot of the volunteers donate as well to the cause. So all the donations that come in, we sort of guarantee that it goes towards the patients and the projects that we do. So we don't like pay the director's fees or hire staff. So we have accountants, lawyers on our board which volunteer full time as well. Danson, why don't you go ahead?
Thank you, Marcus. That was a very interesting talk. So my name is Danson, and I mostly do complex cataract surgery. And the session is about global clinic. So it's about how to do voluntary service outside your own country. And I guess most of you guys are from Europe, right? How many are not from Europe? Only one? How many of you guys want to do voluntary service outside your own country? That's a lot, and I think that's why you're also here today. So basically, I'm from South India, and I have done a lot of my training in India as well. Been to LV Prasad in India and Aravind Eye Hospital in southern India. And recently we started doing non-profit surgery ourselves. We do a couple of thousand surgeries per year. And what we focus on is only cataract. Cataract is one of the most prevalent reasons for blindness in the world. And according to WH, it is actually the one surgery to do if you want to make a cost economic benefit for society. So it's a good focus. here, you can contribute a lot. But to raise those numbers that's needed, you have to really have a lot of help from the outside, and you need to train a lot of people. So basically, I think if you really want to contribute, it's not about only doing surgery yourself, but it's really about education and promoting eyesight surgery worldwide. It means education of optometrists, low healthcare people, and so on. And doing that takes a lot of time, but it's actually part of it. And as Marcus said, the sexy part is doing the surgery. So how does it look like? It looks really basic, and most of the clinics, when you go volunteering, looks very similar. This is the tray to do peribulbar or retrobulbar or subtenal injections, which is often needed because the surgery you do is small incision cataract surgery. So it's only rare occasions you do phaco surgery. It's much more expensive. So basically, on a tray like this, you have for each patient you have a tray here, and this is also a very classic building. It's a small building. Usually, most clinics will have AC nowadays, and the patients will be lined up in beds like this. And this is the guy who is giving the injection. So usually everything is done. So there will be one guy giving all the injections for the morning session. Another one will do the surgery. Another one will do still the sterilization process, and so on. And this is how it looks in the room from the other side. And this is a typical classic setup for OR in a developing country. So you have the microscopes, and you have several microscopes in the same room. So you actually have one OR, one big OR with 3 or 4 surgeons doing surgery simultaneously. And in this way, you can make the surgery much more cost effective. And do you know what the price of a surgery when you do it like this? It can be as less as $15. So this is a really cost-effective way to do the surgery. Most of the surgeries done here is small incision cataract, so you don't need a phaco instrument to do it. This is just the other. So basically, I think you guys have a personal perspective on what to do, and then there's also a global perspective. And what we're going to focus on today is the personal perspective. How do you guys go out tomorrow and start doing volunteering work? Because I think that's what this should be about. There's a lot of places, as I told you, where you can do surgeries really, really cheap. So even your ticket cost is going to cost more than hundreds of surgeries. So is it really cost effective for you guys to go there and do the surgery? Or is it better just to give the money? And basically that is actually really controversial, but I think this is why it's really important for you guys not only to focus on the surgical outcome, but on the education and on how you can actually maybe become partner of a project and help people who live in the local countries become better in their skills by giving them fellowship opportunities or other opportunities. So there's already developed really good economic models for eye surgery, and I think Aravind Eye Care System is one of the best examples of that, how you can do 1 million surgeries per year for the simple cost of €12 per case. But basically, I think the big thing in Europe, and I think the obstacle to do surgery is actually that the level of surgery have to be competent when you go outside your own country. So basically, the people I bring with me have done more than 5,000 cases at least, because they have to be really confident. If we have dropped nucleus cases, we have to transfer the patients to a specific area, and it will take days for the patients to reach, and it will be really cumbersome. So we don't want people who are not very experienced to do surgery. And the dilemma is that most of continental Europe is actually the surgeons start their training very late in surgery. So it basically means that when you can go abroad and do voluntary service is actually really late. and for Denmark, the average age is actually 37. So most of my colleagues who will start doing voluntary service will be 45 or above. So what you need to know is that you cannot expect to do phacoemulsification in developing countries. So you need to learn to do manual small incision cataracts. And how many of you do that? 1? 2? Yes. So this technique is a mandatory thing to learn. And so the next question is, where can you learn the technique? Because obviously you need to know the technique, right? So you can go on courses, theoretical courses in many places in Europe or Canada or US, or you can do a global fellowship program in the US. It's very common that in the bigger universities in the States, you can do a global fellowship program. But if you live in continental Europe, you need to go somewhere to attain the skills needed to do this. And I think a very relevant place to do this is actually India, because India has for decades been the place to go and learn cataract surgery. And it's actually the place where people are really, really good in doing small incision cataract surgery. And there may be a lot of reasons for you guys to go, but you know, for this course, it should be that you want to help people and you want to eliminate needless blindness. So the places you can go is basically divided between private foundations and non-profit foundations. And the non-profit foundations are giant eye hospitals that are world leaders in their field, and they're really, really good. But when you become part of a big institution, you also have the bureaucracy to deal with. So if you want to do a course in these institutions, you have to go through a cumbersome application process. You have to do everything from A to Z and plan ahead 1 year ahead. Also, you have to prepare a longer stay. So you have to prepare maybe to stay 2 months or 3 months in India to go through a surgery. A shortcut for many from Europe is actually to go to private institutions. As in private institutions, you can pay a higher fee and you can get a high amount of case and training load in a short amount of time. So basically, it's up to you what to do. But the most important thing is that the clinic you go to should have all the subspecialty represented. There should be a vitreoretinal surgeon, and you should be, in that way, you should be careful in selecting a good clinic. Otherwise, you will end up being in a clinic where they don't have all the things you need. So basically, there's pros and cons, and it really depends on how much time you want to focus in Asia. So you need to make sure, if you want to do volunteering service, that you go and have a good small incision course prior to going volunteering. And it means you basically have to plan 6 months ahead. And it can be a place where you can do sightseeing, or you can combine your interests. And you need to make agreements and apply for the license to work and practice in the local country. So if you do that in India, you have to do that 6 months ahead, because there's a lot of paperwork for this. And also the visa, when you apply for the visa, you can't go on a tourist visa, but you have to go for the medical visa or the educational visa when you go abroad. So after training, it is basically about practice. And the small incision cataract surgery you can apply in your own practice back in home. If you have wide or hard cataracts, it's really a good way to maintain your skills. And the other thing is actually you need to go outside. So if you don't do that within 6 months' time, you should expect your skills to decrease. So you should have a constant idea of getting exposure to small incision cataract surgery. So how do you utilize your training? How are you going to do it? Now you've done the course, you've done the theoretical course, and you've done the wet lab and dry lab, and been to India for 2 weeks or 3 weeks. So how do you want to utilize the training? So I think for you guys, the best thing is to do something locally. You will meet people at conferences who are doing volunteering work. I have colleagues who come with me when I go because it's local, and then I know the people, and I know what their skill is, and then we can actually contribute a lot together. And when you utilize the training, I think you should try to do it from a local perspective. There's a lot of organizations around, both local and big ones. You can also go for big clinics. But if you start from a local area, I think it will give you much more impact. Yes. Any questions? Nope. No questions. A silent audience. Yeah.
So my question for you is, when you start doing the technique, can you tell us a little bit about the learning curve of getting used to the technique and the cases and the steps in manual small incision cataract surgery compared to phaco? It might be of interest to these.
Yeah, I think the small incision is the next topic for the next session. So we'll come into the details later. But extracapsular surgery and the small incision cataract technique is a really cost-effective way of doing cataract surgery. You have a low degree of astigmatism and a very safe surgical outcome. And you can do it in many cases, and it's a good way to do surgery, especially in the hard cataracts. And the hard cataracts are usually also difficult to do with phaco. Basically, what the technique is, what is important in this technique is the tunneling. And the tunneling is a big tunneling that's self-healing, so you don't need to suture as in a classical extracapsular technique. And that's what makes it very elegant. Yeah. Other questions?
Yeah, maybe can you explain more in detail how you maintain the skill in our daily practices? Like, what will be the choices for the...
Yeah, that's a really good question, because when you've done the training course, if you don't maintain the skills, like anything else, you will not be able to perform the surgery. And what you should do is, when you have complicated cases in your own country that are white cataracts or brown cataracts, you can do small incision cataract surgery in those cases. And that's a good way of maintaining at least some part of the skills. If you really want to be good in this, you have to do at least 200-300 cases per year to maintain the skill on a good level. But that's how surgery is. If you want to do good phaco surgery, you need to at least do 500-600 cases per year, right? So it's part of that.
Thank you so much, Johnson. That was very inspiring.
Thank you.
So our next speaker is Jaya. Yeah. Our next speaker is Jaya Chidambaram from the UK. How to work in India.
Thank you. I'm hoping that my laptop will actually connect. We'll try this again. Yeah. It's not doing anything now. Oh no.
Nope, I didn't bring mine. Should we try to... Do you have it here?
Yeah, it's not.
What is it? Is it your PowerPoint is not working? Is it this one? No, it's working.
the laptop?
It's showing the
It's for the video?
No video. Just like it's open, like the presentation is not showing.
I search it.
It's moving. It's just
Alright.
like I opened it, but it's not opening.
Okay, I understand. I will call a video technician because I'm only a sound technician and I don't understand something.
So from technical reason, we need to have 5 minutes break, and then we will carry on.
It's not projecting the actual PowerPoint. It's here, it's moving around. It's moving. Yeah. So even if I open it, it's changed the resolution after we plugged it into the thingy. Yeah, that's it. Yeah. Now it's come back. Thanks, Steve.
Okay. So please have a seat. We can carry on.
Thank you. We'll give people a break. I'll borrow this one. Okay, so now we've resolved our technical difficulties, so feel free to join us again. So just to introduce myself, so I'm Jaya. I'm basically an ophthalmologist. I did my training in the UK and London region. Then I became increasingly interested in working in India. So I did my medical student elective in South India in Aravind Eye Hospital, the place that Danson was telling you about earlier, and was just really impressed with the work that they do. So I stayed in touch with them for many years and became more interested in doing research with them. So Aravind are based in the very southernmost tip of India, very, very hot region, very beautiful. Famous for its exciting food. So I don't know if you guys have seen these before. So they're called dosa. They're rice pancakes, crispy and delicious, specialty of South India. I recommend traveling there just for the food, actually. As well as the surgical and research experience. Also, there's a lot of exciting history and architecture in South India. Madurai, the place that Aravind is based, is very famous for this incredible temple complex that was built in 6th century BC. So it's very beautiful, nice to see, steeped in history. Also, another reason for going to India is to see very, very interesting cases. So as Danson was saying, it's a place where you can really learn about the pathology of diseases and see quite end-stage diseases and quite hardcore cataracts, which really stretch you to the limits of your knowledge and your surgical abilities, actually, and gives you the potential to be a better ophthalmologist. So I chose to go to Aravind Eye Hospital for a longer time period, actually, to do some research, to really delve into things like this that I was seeing more and more at the end of my kind of residency training in London. In contact lens wearers. I became more interested in why we can't treat these more effectively. So I thought, actually, the climate in South India predisposes to kind of very bad infections. It's a good place to go and study this disease. So I wanted to talk to you a bit about how to go about working there, how to go about setting up a research study there for a longer time period, like a year or a few months if you want to. So the first thing, as Danson was saying, is to consider getting some kind of medical licensing. So if you have a look at the Medical Council of India, their website, there is an actual way of getting a license to work temporarily as an ophthalmologist for postgraduate qualification or for research. So it costs around 5,000 rupees. You can download the application, have a look at it on the website. So you need some help from your institution to fill it out. So you basically need them to stamp and approve it. You need their help to get a banker's draft, which was an exciting experience for me. Never got a banker's draft in Indian rupees before. So they can help you to do that and fill it out. It actually doesn't take that long to actually get your registration. Maybe, I think it was 2 months or something like that for me, with the help of Aravind. Also, it's worth talking to your indemnity insurance providers. So people like in the UK, the Medical Defence Union or Medical Protection Society, because you may need some coverage if you're doing surgical procedures in another country. So this may vary from country to country, so it's worth thinking about that and talking to people about it. So I talked to my friendly people in the Medical Protection Society and got indemnity insurance because I was also going to be learning corneal graft surgery, penetrating keratoplasties, when I was in Aravind. So then I started to think about planning a research study there. So you may want to think a little bit about, do you want to just go for a month if you only have a month in your residency training, or do you want to go for 3 months, something a bit longer? Have a timeline, have a plan of action, start thinking about who might be able to support you, a good supervisor who's got a little bit of experience of working in other countries, or working in India, in fact. Think a little bit about if you're going to do part of a clinical trial, maybe how many patients you might want to enroll, get some help from a statistician. Think about if you might need any fancy equipment, and think about how you might get the funding, and start to think about how you might order it and ship it to India. And finally, you might be lucky enough to be able to hire an assistant. So you could think about that too. So then, because this was a research study that I was doing, I had to get ethical approvals. So for us in the UK, it's become an increasingly more straightforward process. You just fill out your forms, takes about 4 to 6 weeks. However, it's a bit longer in India. So I was lucky in the south of India, the institutes like LV Prasad and Aravind are used to doing bigger clinical trials, so they have a more rapid process. So it took around 3 months to get the approvals, which is not bad. But then because my research study was going to end up being published, everybody advised me to get national approval from the Indian Council of Medical Research. So that's a big process. And as Danson said, you should apply 1 year in advance. So by the time you get it, so I was very lucky that I got mine 9 months later, not a year. So it's quite a big process, something to think about if you're planning something like I did, a PhD project over in India. It was a very interesting experience because they're not quite electronic. So I had to print out 30 copies of my study protocol, bind it and send it, because they're a government organization. They only allow you to send it with the equivalent of Royal Mail in the UK. So you have to send it through the National Postal Service in a cardboard box. So plan for these crazy eventualities as well. You never know what's going to happen. Finally, my university wanted me to have a research contract. So the lawyers between our university just drafted a standard contract agreement to say, okay, you're allowed to go and work in the Indian Institute, and the Indian Institute says, we'll give you some lab space and office space and let you see our patients, and everybody signs it. So that was actually quite quick. It took about 3 months. So then you got really excited. You got your approvals. You can go to India, start your clinical trial on your new drug, or test out your new intraocular lens or whatever. What are you going to do? So then I started shipping my equipment from the UK. So I got really excited about doing things like PCR, molecular things. A lot of the equipment has to come from the Europe or the US because it's not yet being developed in India. So I ship things from QIAGEN in the Netherlands. I ship stuff from the US, Life Technologies, and my trusty confocal microscope. I bought one and shipped it from Heidelberg in Germany. But I didn't understand that this stuff can get stuck in Indian customs. So I was so excited that I was going to start, but I had to be delayed by about 2 months whilst negotiating to pay the taxes in customs in Chennai. So be prepared for delays. It can happen. can happen. But the nice people in Aravind helped me because they're used to shipping things from all over the world. So befriend the people in the institute. They can save the day. So then finally, I got to the clinic and I thought I can enroll patients. Great. So then I realized that although my family is originally from South India, I'm not used to having technical conversations with my friends and relatives about their eye pain or glare or light sensitivity. So I realized that technical terms actually where we may need some help in the local language. So I was lucky enough to be able to hire a research assistant who could speak Tamil but using the medical words required to have a conversation. So it may be that you could start to learn those words over the first few weeks, but it's also nice to have some help, either a nurse or a research assistant, so in my case a microbiologist who worked with me. I translated all my patient information forms and consent forms into Tamil, the local language in around the Aravind region in Tamil Nadu. So then finally we could start the project. It's very exciting. So we got a room where we could set up. We had our confocal microscope. We could enroll patients, examine their ulcer, measure everything, use the slit lamp. It was very good. So then how about life in India itself? So think about the type of visa that you might need. So you might need a very specific employment visa, but it is quite straightforward to actually achieve that in the embassy in your country. Think about if you're okay with spicy food. I loved it. It's an exciting adventure. Also, the climate, particularly in South India, is very hot and humid, so you need to plan if you're going for a longer time period, even 4 or 6 weeks. Take enough mosquito repellent, some good sunblock, be prepared for the heat. Yes. Think about air conditioning. It's very nice to have that periodically in your accommodation. And beware of the mosquitoes, as we talked about already. Yeah. And then finally, you have exciting adventures when you're there. So this used to be my method of commuting to work every day. The auto rickshaw, me with my iPod, listening to music on the way in. It's very nice, very exciting. So finally, just to give you a few slides about what I was doing. So this is the kind of stuff that would rock into our cornea clinic in Aravind Eye Hospital on a Monday morning, or in fact any day of the week. So it's a very, very bad fungal keratitis patient. And we were able to see from the corneal scraping some nice fungal filaments, hyphae, and again the images from the confocal microscope confirming the hyphae. And nice ring infiltrate, giving you a clue it might be acanthamoeba, which we confirmed again with the corneal scrapings and confocal microscopy. And finally, although India is considered a developing country, there is a lot going on in the background. During the time that I was there, the last 5 years, increasingly the biotechnology facilities have become incredible in some areas like Bangalore and in New Delhi. So I found at the end of the day, it was easier to do my high-tech sequencing in India. Even though I had planned to ship everything to the UK, it was remarkable. So actually, although there is a rich-poor divide, you can do incredible research actually in India itself. So here's some images of the corneal tissue taken out at the time of corneal transplant surgery. We were doing some molecular biology work on it in India, actually. It's very exciting to be able to do this stuff, despite the fact that it's considered a developing country. So there you go. I feel that working in India can give you a very exciting and rewarding experience. I learned so much about corneal disease just by being in the cornea clinic probably for 1 day. So I would recommend it. It makes you a better ophthalmologist so that the severe diseases you see when you return to your own country, you feel more confident in managing them. Also, it's a unique insight into how to run a very busy clinical service. So someday when you become the head of your eye hospital, you'll have some idea about how to create an efficient service, whether it's for high throughput surgery or whether it's for a busy cornea clinic. Finally, start planning even a year in advance so that you can sort out your visas, you can sort out any research paperwork like agreements, ethics that are required. Plan carefully what equipment you need, and if you think it will take 2 weeks for it to get there, triple the amount of time. Standard project management talk, it turns out, because you may have delays on shipping things to the country. And just enjoy the experience, just the food. The people you meet may become your lifelong friends, actually. because it's quite an amazing experience to be there and learn surgery or do research there. So I would recommend it. And feel free to get in touch with us, any of us, if you want any further information, because we've done it and we can help you. And that's it. And any questions?
You mentioned the language barrier. What would be, on top of your mind, the other possible barriers for someone who wants to apply for the training? Or because majority of the doctors from Europe, they don't necessarily hold the GMC. So if it's like realistic for them as well to, what's your view on it? If you have.
So I actually did the cataract surgery, the phaco course at Aravind many years ago, about 10 years ago. So there is quite a strict application process, but you can actually see a lot of that online. So it's worth actually doing a bit of research by looking at various institutes' application processes for a phaco course to see what they require. So when I applied for the course, I think they wanted to know about your surgical experience before you actually applied. So they want to know, have you done sections of phacos? What bits are you confident in? Have you done, 5 phacos already? Or they want to know about that first, and then you can seek out that experience at home first, so that you will be accepted in their program. Also, it can be expensive as well, so you have to think a little bit about that.
Thank you. Any more questions from the audience? So then I will give a microphone again to Danson for his next talk.
So it's so you may wonder why India is mentioned many times, because there's so many places you can go and do voluntary service or learn surgery. But the thing is, if you are from the States, the classic place to go is South America. Because there's a lot of clinics, and some of the big hospitals in the States also have their own clinics in Africa. But if you're from Europe, there's not a similar kind of affiliation. So that's why if you need to learn surgery, you need to go somewhere. And the place where that's most convenient for your time span would usually be somewhere like India. So the surgery we would like to emphasize is small incision cataract surgery, MSICS, and extracapsular surgery. And Marcus will discuss in details about extracapsular surgery, and I will put my emphasis on the small incision cataract surgery. Are there anyone in the room who are doing the classic extracapsular extraction surgery? You do it in Turkey? Yeah, you did. Which is a very good technique to know. It's a good technique to convert to. I think I only have 5 cases per year where I do extra cap, and usually it's cases where I need to convert, but where there's not time enough to convert to a small incision cataract. So it seems like it's working, right? There are many ways to do surgery and many ways to do small incision cataract surgery. And it basically reminds me that there are many ways to Rome or wherever you go. And doing small incision cataract surgery, if you go for a course, you can find many ways to do the technique. Some will start in a different order, and some will do it a little bit differently, just like when you start learning phaco. Basically, the way I do it is the way people will do it when they usually only do small incision cataract surgery. And then there's some small tips if you are usually a phacosurgeon, how you can use those techniques to enhance your small incision cataract capabilities. Basically, the steps for small incision cataract surgery is you need anesthesia, and because you are doing a scleral tunneling, you can do local topical anesthesia, but it's much more cumbersome and you have to apply it very often. So it's much more safe to do it, especially if the surgical time is prolonged, to do it as a subtenal or retrobulbar injection. I think subtenal is much more safe if you're not used to giving injections, as you can prevent the risk for globe penetration. Then after that, you will do the side port. Because doing the side port is convenient, because most of the guys from continental Europe use the Rexis forceps. How many of you are using the needle instead of the forceps? How many use needle? How many use forceps? It's typical UK people who like to use the needle, right? The sister term. So if you're using the sister term, it's really convenient when you go out because it's cheap and efficient. But if you're using a forceps, a good advice would be to bring your own Rexis forceps. One will be enough because they can sterilize it in between the surgeries. Then you need to be good in doing the capsulorhexis, and there are different techniques I will talk in details about. After that, the sclerocorneal tunneling, internal corneal incision, nucleus delivery, and then you have to remove the cortex, and for that we use a Simcoe cannula. And that is not only something you will use in developing countries, they use it many places. I think UK, some of the clinics use it as a standard to remove cortex. And in the end you seal the wound, sutureless. I would like to show you this video just for a quick way of how to remove a black cataract. This is a video done with the mobile phone, because in my this is when you are out there, you may not have the best microscope HD quality video. But here, what you see is first you do the peritomy, and then you do the large corneal incision. And what you do is actually you use a crescent knife to dissect into the cornea. And what is important is that the dissection should be 2/3 into the cornea. If you're too much on the top, the problem is you may get buttonholes. And if you're too much on the down, the roof is not strong enough. And this is the most difficult part. If some of you are used to do trabeculectomies, this will be a little bit easier. The side port, injection of vision blue. Remove it, then in this case I do a corneal incision, into the cornea, into the AC, and I use a needle here, and that's why I can do the Rexis through the big incision. So if you're using the forceps, you cannot enter through the main incision, as you will lose the AC. In that case, you need to do the Rexis through the side port. And here we are doing the Rexis. This is a black cataract, so already the view is bad, and it may. So you should also another thing you should expect is that doing surgery in some developing countries is also a little bit cumbersome, because you're used to having the best techniques, the best instruments that's available, and when you're there, you don't have it. So you have to use what you have. And this is a nice Rexis. This is a CCC. And the next important skill is actually, because this is a black cataract, you don't need to do a big hydrodissection, just a small one. Rotate the lens. You have to make sure the lens is loose from the back. And here I apply a bimanual technique with the IO spatula, which you put underneath the lens, and then you prolapse the lens into the AC. And this is a bimanual technique. You have to be cautious about not getting the back. You dial the lens into the AC, as you see here. And you have to be very careful in this process. Here the lens is in the AC. Then you can use whatever loop or fish hook to take the lens out. And look at the lens. It's pretty black. And even in these cases in Europe, I will perform a small incision cataract than doing a phaco. I don't do the traditional extracapsular because this is a very nice self-healing wound. And here you can see the Simcoe cannula to remove the residual cortex. After that, you inject viscoelastica. Usually it's HPMC in these countries. And then in this case, I put in a 3-piece lens because that's what was available. 3-piece lenses are good to use because if you cannot place it in the bag, you can always place it in the sulcus. Otherwise, we prefer to use PMMA hard rigid lenses because they are really affordable. You can buy them for a few dollars. Here you dial the lens into the bag and make sure the lens is in the bag. After that, you clean and remove the viscoelastic material and close the wound and close the conch. And always use antibiotics post-op. I know in the States it's not common to use, but in these cases in developing countries you should always use moxifloxacin in the AC. So I'm going to give you a step-by-step approach to have a good idea of how this should be done. So basically when you have the eye like the globe like this, the first thing is to use some kind of anesthesia. And if I were you guys, I would prefer to do a subtenual injection here. It's safe and efficient, and there's no risk, very low risk for any kind of globe penetration. Then I would do the side port, because most of you guys are used to do the rexis with the forceps. Then you inject viscoelastica and remove the viscoelastica. Then you do the rexis. And usually you're used to do a rexis that is 5.5 millimeters. But in these cases, it's really, really important to make a huge rexis. Even 6.5 will be okay if the nucleus is big and black. So a huge rexis is sometimes not easy to do as a CCC. As you're going out to the periphery, there's a risk that the rexis may go out, maybe running out. That's why in some of the cases, if I know this from the beginning, or if I have a case where the pupil is small, I may actually just do a can opener from the beginning. And can opener technique is something that's mandatory to know if you're going for these cases. And basically, you use the cystoterm and do the can opener technique 360 degrees, as you can see here. It's actually a really, really good way for big nucleus because there's a high pressure inside. And because you have a lot of small tears, the risk for one tear to go behind is very, very less, actually, very small. Another technique I sometimes do when I'm in a hurry, because if you have 60 cases a day, sometimes in the end, you will be in a hurry to finish the cases. You need to do it good and safe. There you can actually do it like an envelope. It's one of the first ways to do a rexis, actually. You cut into the anterior capsule, and then you make a rectangular appearance like this, and then you actually just peel the rexis off. And this is actually a quite stable rexis, and you can implant a lens nicely into the back. You can also do it differently. You can do it like a V, and then peel the rexis off. So in these cases, the most important thing is to give a safe outcome. And sometimes this is a better way to do it. So after that, you have done the side port, you have colored the anterior capsule. The next is to do a peritomy, as you see here. The peritomy is really, really simple to do. You dissect, and after that, you measure 5.5 millimeters. You can actually do it much less than 5.5. You can do it 3 millimeters. But if you do it small, you need to be really experienced. If you do it big, it's easier to do the rest of the process. So 5.5 is pretty much standard. And incision should be 2 millimeters, 2 to 3 millimeters behind the limbus. Then you do a main incision like this. And then you use your crescent knife to dissect slowly. And I think this is the most difficult part in the process. When you do this, you have to be really, really careful because you want the dissection to be in one planar. You don't want a multi-layered cornea looking like this. And if you're doing a buttonhole in the top, you can always go back and dissect from beginning and do a new one in the same place. Do you get me? Yeah. In the end, after you've done the nice dissection, you enter the AC. And then you go out to the side. And then you have a nice self-healing tunnel. I'm just going to show a quick video just of how to do the initial tunneling. I'm not going to show the whole process, but just to show the peritomy is here. Just open up the conch, and then I do this very straight incision, which is very lazy. If you don't want astigmatism, you should do a thrown incision. But if you do a thrown incision, you also have to take into risk of moving the eye from side to side. I feel if you do a straight incision like here, it's much more convenient. But you will have much more astigmatism doing this. So here you see the main incision, how you enter the cornea. So now you have done the tunneling and you have done this, so everything is good, right? So you're done with the surgery? Not yet. The next step is doing the rexus and so on, but after doing the rexus and the hydrodissection, it is actually to prolapse the lens into the AC. And I think this step is the most difficult after doing the tunneling, because these are the two steps you're not used to do in a traditional phaco. So the thing is, you want to prolapse a big lens into the AC. This is not a clear lens extraction. It's not a soft lens you can just push out. This is a hard cataract. So the dissection should be really, really gentle, and it should be in different places. Then you need to rotate the lens, and then you need to push it up to the AC. And there's different techniques of how to get it up to the AC. One is just to use an iris hook on the side and push it up. I'm going to show that in a moment. The other technique is basically to do it manually. Did you remember the first video where we had an iris spatula? You can put it underneath the nucleus and then put it up. Then when the lens is in the AC, you just remove it. And when you remove it, you can use any kind of loop to remove it, or you can use a fish hook. Everyone knows what a fish hook is? Yeah, it's just a needle you bend and then just pull it into the nucleus and take it out. It's very simple. So after that's done, you use a Simcoe cannula, and that's very convenient. Most phaco surgeons are very comfortable in doing that, removing the cortex, inject the viscoelastics, and then inject the lens. In some clinics, they only use PMA lenses that's hard and rigid, and in those cases, you have to be really, really careful, as you may risk penetrating the bag when you dial in the lens. And in the end, you close the wound and hydrate the side port, and then you're done. Just one final video I want to show you. So here you see a mature white cataract, and here we're doing a peritomy. Sometimes it bleeds more than then you can use your diatomy to burn it. And here you do the incision. This is a critical step where we use a crescent knife and dissect slowly in one planar. And what is really, really important, you may see in this video, is that you go out to the sides. This is a really critical step, is that you go out to the periphery on both sides. Because the lens is much bigger than the main incision, it has to have a triangular appearance. That's the way to get the lens out of the bag. So this is something I spend a lot of time on doing. And here I do the side port afterwards because I use the cystoterm. Vision blue is a big help, and you should always use vision blue when in doubt. Most of the microscopes in these places are also horrible, so vision blue will be a big help. Again, that entering AC, as you see here, look how much triangular we are going on both sides. That's really, really important. Rexus is done here. And very often in these cases, because if you're going to Africa, Asia, they have dark irises, big, thick irises. So it's not uncommon that the iris, it's a mid-dilated pupil like you see here. And that's something you can actually practice at home, is actually using the cystoterm. I think if you want to do a voluntary service on a systematic manner, I think this is also something you need to practice, but that you can do at home. Cystoterms are easy to bend yourself and not costly. Look here how the lens is prolapsed out. Here I just use the side instrument to prolapse the lens into the AC with one instrument only. And then you put in viscoelastica and I prefer to use this loop to take it out in one piece. And after this, you use a Simcoe cannula to remove the cortical material. And now you're almost done. You need to put in the lens. Sure. So this loop, actually, it's connected, so you can use it to flush. So you can actually increase the pressure in the AC, flush it out while I have it under. But some of the other kinds of loops are actually where you can put something on the top and take it out like one piece. And another, so there are different ways to take it out. Sometimes you can actually just inject saline into the AC and it will come out itself. Here the lens is in the bag, one part at least, and now you dial it in, as you see here. And what is important is that you have to be really, really careful when you dial in, especially if you're doing a can opener technique or envelope technique. You have to try to do it in the first time. You don't have you can't just manipulate it too much in the same way. And if you're not sure, you should just place it in the sulcus from the beginning. So if you're not sure you're able to manipulate it in, just put it in the sulcus if it's a 3-piece lens. And here we are closing the conch, and surgery is done. So do you know, this is the type of surgery, it looks like it's really time consuming, but for most of the experienced surgeons doing it, it's really fast. And it will take me 7 minutes, but for my colleagues in India, some of them will do it in 3 and 4 minutes actually. So it can be done really, really fast. Thank you. I think Marcus will tell you a little bit more about the traditional extracapsular surgery. Any questions? No questions. Are there any complications of the procedure? What are the complications? It's totally risk-free now. I wish it was like that, but there are all the same complications as we see in phaco. When you're working in rural areas, what you fear is a dropped nucleus, because you may not have the same vitreoretinal support as you have in your normal clinic. All the other things you can manage. You can have iris prolapse. It's very, very common because you use anesthesia behind, so it's a good massage of the eye is good. leakage of the wound is common if you're not used to doing the tunneling, so you should suture it. Antibiotics is therefore highly important. You can break the bag when you put in the lens. Most of the rookies I've seen, the problem is usually the wound, or when they put in the the PMMA hard lens, they break the bag actually. Also, a difficult step for many is actually the rexis, because they are so comfortable doing the rexis one way with one instrument and only going to right. And when you are out here, you need to be really confident doing the rexis and doing different techniques and change in between the techniques. That's actually the most important thing, is to be very, very flexible, because you're not going to have the same instrument as you're used to have. Thank you.
Thanks, that was great. I just want to know one thing. What mobile phone were you using? That's amazing.
Yes. That's an ad for Samsung S10, right?
It's fantastic. That's a good tip. I'm going to do that. Well, in rural countries, like you said, I can't get videos. So actually the videos here are from Singapore itself. So for those people who just joined us, just a quick introduction. I'm from Singapore. I work at the Singapore National Eye Centre. I'm a cornea and refractive surgeon, but I also have an NGO, so we go around to Asia doing free and voluntary work. Part of our work is to do cataract surgery, which is one of the leading causes of reversible blindness in Asia. And so everybody here, I guess you started training straight into phaco. Nobody started with manual first, right? Okay, so that's the situation in my residence. Oh, do you start manual? That's fantastic. So I started. Okay, I'm old enough to start with manual surgery, so we were mandated to do 100 ECCEs. This is like almost 20 years ago. And that was the start of my training, before we could even start a single phaco. But my current residents all start with phaco immediately, right? Because there aren't enough ECC cases in Singapore anymore, and it's just the way training's evolved. So I think what's happened is that the skill set that we had when we did manual surgery, now you got to pick up later. So it's like the other way around. So what I'm going to share today is an ECC video, which actually it's from one of my residents, because I don't do it anymore. And then I'm also going to show what I teach my residents, my MSICS technique, which is a variant of the well-described techniques that you can find in YouTube and publications, but from a person who started with phaco point of view. So a lot of things that you talked about, I sort of like talk about here. So if you only done phaco and you're starting MSICS, and so the videos you see here are me teaching my residents in Singapore with a really good scope how to do MSICS, right? So first, ECCE. So there are big differences between ECCE and MSICS. ECCE starts with a conjunctival peritomy, as you can see, but it is a corneal incision. Now, the reason why in Singapore we started with corneal incision manual surgery is because it's easier to teach. You know, the scleral tunnel, as Danson had mentioned, is a steeper learning curve compared to a corneal incision. So you first start with a side port blade and you create a 50% depth, and then you enter the AC and fill up the AC with viscoelastic. Okay, that gives you the tension that you require before doing the capsulorhexis. And we teach capsulotomy first before rhexis, because from a resident's point of view who's never done any ocular surgery, that's a lot easier to learn. So basically, you know, just making sure that you have 360 capsulotomy, right? As Danson had shown. Yeah, so the view, sorry, is pretty bad, but basically as Danson had shown, that you're basically just going 360. Next, we use a corneal scissors to enter the anterior chamber, and what we're doing is creating a two-plane corneal incision, which requires still a lot of skill, but less in terms of people who've never done any cataract surgery before. And you can see the iris prolapsing out already. And because the wound is so big, from 3 to 6 o'clock, you know, the risk of like hemorrhage, capsule prolapsing out, iris prolapsing out is actually very high. So what we're doing is actually what you saw was basically an external pressure, which is not good. So you can imagine if a patient already has pseudo exfoliation or zonulisis, the bag sometimes just comes out together with that. So it's not a fantastic technique, okay? After that, you have to put temporary sutures because you need to maintain the anterior chamber before going back in through that one of those wounds to do the IA, to remove the SLM. and then release that 12 o'clock suture to put the lens in. So from a perspective of somebody who's not done any ocular surgery, I think the advantage of this is that a lot of the surgery is extraocular, meaning that the only time you actually enter the AC is making that cornea incision, doing the capsulotomy, and putting in the lens. Other than that, everything is quite extraocular. So the learning curve in some people's minds is less than compared to SICS. Any questions for ECC? Anybody done this before? Okay, so it's not. Yeah, but then SICS, the people who do ECC, do you do SICS? No. Yes. Yeah. Okay. So it's the same people, but as you can see, you need like 7 sutures. 1, 2, 3, 4, 5, 7 sutures at the end because it is a relatively large wound, only 2 planes, and even then, some residents when they start out do struggle getting a self seal. The sutures need to come out sequentially over the next 1 month, 2 months. Usually, we do keratometry, and it took me probably maybe 30 or 40 ECCs myself before I got like an astigmatically neutral suture. That means I sutured it, for a person who's never sutured a cornea. So the other thing that's another advantage of this for our residents is basically they learn how to suture a cornea. So if there's a trauma or a perforation that requires suturing, that's not something they can't do on their own in the middle of the night. So cornea suturing comes easier. Right. Oh, okay. So I did lay out the steps. I was meant to press this while I was coming. So any questions about ECC? So it's something that we still do in Singapore, but we're doing less and less of. And this is something that we cannot do in rural countries because, firstly, the patients don't come back. They're very poor to follow up. So if they're working in the farms, they don't come back. They have 7 sutures in their eye. They're going to get suture-related infections. They come loose. There's no way to check them. And there are a lot of issues with like prolapse, tissue prolapsing out. So if you summarize the difference between ECC has a large cornea incision, multiple sutures, so you have potentially a lot of suture-related complications. There's a lot of astigmatism. In my first case, I'm sure it was like -7, -8 of astigmatism with the rule. There's a lot of pressure during the nucleus delivery. So if you have pseudoexfoliation or loose zonules, everything comes out. It becomes an ICCE, right? And so vitreous comes out. You need to put an ACIOL. There's some questionable value about it being easier to learn. As Danson has already shared, the M6 uses a scleral tunnel. So it is a bit challenging in terms of if you've never done ocular surgery before, it can be quite challenging. It is sutureless, although I do recommend putting a single suture sometimes, especially if you're not sure if you're going to see the patient again and you're not sure if the patient's going to be compliant with eye rubbing, much less cornea astigmatism. And actually, for even till today, if I have a very, very dense nucleus with zonulitis, I do SICS because the gentle delivery does save the bag sometimes. And however, the nucleus delivery, when done wrongly, so somebody asked about complications, can lead to very traumatic, a very major trauma to the iris, to the bag. Everything can come out. So it can be. Nonetheless, as Danson has already mentioned, it has been shown to be a cost-effective measure or technique. It's technology independent. All you need is a scope and good set of hands and some instruments. It's really useful for complicated cataract surgery or mature cataract surgery because you're not using any energy and you're not going to fry the cornea. And being a cornea surgeon, that's something which I don't like. It's potentially faster, so Danson takes 7 minutes. I'm not that quick, but in most hands, you do it very, very quickly. It can be very fast, sometimes faster than phaco, especially in a mature cataract. And you can get visually good outcomes. So actually some interesting papers coming out in ophthalmology showing how the learning curves of residents perform doing SICS, either in Aravind. There was another paper in another center. This is a bit harsh. I don't know what you think about this, but they recommend that a resident should do 300 surgeries before they're comfortable with M6. I think that's probably correct if you've never done any ocular surgery. But if you're an experienced surgeon, anterior segment surgeon already comfortable doing cataract surgery, I don't think you need that many cases before you can become proficient. So actually, yes, this was in iWorld, and I just shared some perspectives of people transitioning from phaco to MSICS rather than the other way around. So that inspired me to come up with this video, which I'm sharing now, which is basically some tips for beginner surgeons who are already familiar with phaco and they're exploring MSICS. So number one is really learning how to do an adequate scleral tunnel. I think the basics has already been covered by Danson, but just to emphasize, the scleral tunnel has to be big enough for the nucleus. So if you're doing a NS2 plus or 3 plus cataract, you don't really need that large a scleral tunnel. But what I noticed from my residents is that if the nucleus is very mature and they do a very, very small scleral tunnel, that's where you get in trouble. So that's when you're pulling out the nucleus and you're traumatizing the iris and you just can't get it out, and then you go in, make the wound larger and it's bleeding everywhere, so that's when the trouble starts. So whenever my residents start as M6 training, I get them to do a larger than necessary scleral tunnel. The nucleus just pops out just by staring at it, and it makes everybody happier. Later on, as you get more and more experience and familiar, then you can start challenging yourself by making the tunnel smaller. And there's no pride in like suturing your first few cases because you made such a large wound. Secondly, as Danson has shown, the side port, I mean, a lot of people use the side port for various reasons, but later on you can see in the video, I make a very large side port. And the large side port is equivalent to your own phaco wound, so that allows all the steps to be done through the phaco wound, that wound, right? And the main advantage is, number one, if you're used to doing phaco, like using your intratas and all that stuff, you can do everything as you were doing in your usual phaco cases. And number two, you avoid going in and out through that scleral tunnel, because initially, when we first start learning our tunnels, we tend to have a very uneven or traumatic scleral tunnel as we are learning. And going back in and out using that cystotome or intrata just makes things worse. So having that side tunnel really, really helps. Later on, if you get more and more comfortable, you can go in through the main wound with a very, very small side tunnel. I usually get my residents to never, so unless you're doing thousands like Danson, I tell my residents to never put any instruments. Vectis, there's fish hooks, there's slide glides, there's all kinds of stuff that people just go behind the nucleus and pull it out. But for my residents who start out, I tell them not to, because basically if you're not familiar with that angle and the depth in which you're putting it, inadvertently somebody will poke the posterior capsule, right? Because you can't see, because basically if you have a very dense nucleus, you can't see what's underneath. So I always encourage people. Later on, I mean, obviously, as you can become more experienced, you can do anything you want. But if you're just starting out, I tell them not to. So it's like more like a visco expression, and that comes with an adequate scleral tunnel. And last but not least, I suture it. So here's the video. Sorry, it's a bit. It was done by one of my technicians. I hope I can play it. Play, please. Okay. So it looks very commercial, but it's meant for my residents, and it's a bit slow. And so because I was doing this at SNEC, I had an intra OCT, so not that it added any value, it's just nice to look at. But I'll be showing, in the video, I'll be showing the steps which I mentioned before. Probably not as good as the iPhone, the Samsung. Yeah. So this is just a contraparadomy, just to show that. So typically would you sit at the top, or I do? Yeah. So typically most surgeons sit at the top. I sit temporally. There are advantages and disadvantages of each. It's generally easier for my residents because they're so used to sitting temporally for their phacos. But if you're doing your phacos from the top, that's fine as well. So I use a phaco-sized blade for a side tunnel, side port. So it looks like it's overdoing it, but it really helps my residents because they're used to doing rexes using the side port, using the phaco wound, and they're used to basically maneuvering around that. So, and the other thing that the residents, I notice about residents when they're first learning is that in phaco, your instruments are always downwards. So basically when you're putting your intrata in to do the rexes, you're used to a downward action and rotating it. Whereas in SICS, if you do everything through a tunnel, you're going upwards. So a lot of residents struggle because they're going upwards and away and pushing the eye away from you, and they They can't do the rexes. They can't do any of the intraocular surgery because it's very, very difficult. Okay, that happened very fast, but basically what I was showing is basically sort of like a rotation and injecting viscoelastic behind the capsule, behind the lens, and just trying to get that nucleus out rather than putting instruments behind the nucleus and pulling it out. And once that's done, the rest of the steps as described. The other advantage of having that large site wound is that you can do the IA through that wound as well. Again, for somebody who's never done manual surgery, to do IA, putting the instrument upwards through the tunnel and then downwards into the bag is very, very difficult to catch the SLM. So having that wound at the side to just go downwards, it's intuitive for a phaco surgeon. All right. Yeah. So you can do this either temporally or superiorly, it doesn't matter. And I think most of my residents feel much more comfortable. And then later on, as you get more and more experience, then you can do the IA through the main sclerotunnel, which is much faster. You sort of depress the wound and all the SLM comes out, but the posterior caps, the anterior chamber completely collapses, and that's very scary for a surgeon who doesn't do much cataract surgery. And last but not least, you can put a one-piece foldable lens through that large wound again. Everything just like a phaco. So essentially, you're just doing a phaco, except you're doing a sclerotunnel and delivering it through the sclerotunnel. Otherwise, everything else is as perfect as a normal phaco. And at the end, just a suture of the wound. So that's sort of like the way I teach my residents. They find it useful, and then later on, as they become more and more experienced and confident, then they'll start doing it the way Danson has described, which is faster, but it's a lot scarier. Everything through that sclerotunnel, everything just wants to come out, SLM, anterior chamber, shallows all the time. It can be quite challenging for somebody who's not used to it. So I think 300 cases is a bit severe, but I think 10, 20 cases, you should get the hang of it by then. All right. So, again, welcome you to Singapore in the future, next year, January, if you're interested. Any questions? For myself or Danson, actually? Any comments on?
I just think the way you did the surgery is excellent. It's a good way to do it when you are a routine phaco surgeon. I think for most phaco surgeons, they're so used to do it in a one particular manner, just a sudden step that's not in the same way, they become a little bit nervous. So I think this is the way to do it when you want to do M6.
And just to answer Danson's question as well, so how do I keep doing it? I mean, how do you maintain your skills? I think even once you've learned the skill, once you're back in the center, the moment you have a dense or hypermature cataract or pseudoexfoliation, or you think this guy's going to need an ACIOL anyway, then just do it in your hospital. That's the way to maintain that skill. I think visiting and having a course and wet labs are very useful as well. But we are starting to do our training for our anterior segment fellows to do SICS. If it's a sublux cataract, you can combine this with slow fixation. Or if you're pulling out IOL that's dislocated or old ACIOL, you can do a practice during a tunnel, take out the ACIOL. So that's another way to learn.
And also for the iris claw, you can use the same self-healing tunnel, actually. So you don't have the same level of astigmatism.
Yeah, question?
Can you comment on conversion from phaco to those surgeries? Is there like a certain type of incision, like location, size? I think it's more useful in the phaco era, right?
Yeah, I'll go first, and then you can. So in the past, what we used to tell our residents is that, if you have a very large chunk of nucleus left and you're going to convert, what we'll usually, I don't know what you guys do, but some of them would actually convert the phaco wound into a corneal wound, and that would become an ECCE. So then they have to suture it. So remember this technique, I'll just ask them to move to the top, use that side wound as your phaco wound that you already created, and do a sclerotunnel from the top, and then now you've got that technique which I just described. So everything is back to normal, just that you have to do through the sclerotunnel, suture that, and if you need to do an anterior vitrectomy, you can also go through the main wound. So I find it very hard to suture and seal a wound that you kind of like extend from a phaco or use a knife. That's when the leak starts happening, and the suturing. Yeah, you can never get that nice plane. So I always tell my residents to leave that phaco wound alone, move to the top, open up the conch, and do a tunnel. I don't know what comment you have about that.
So it also depends if your beginners, your trainees are doing it from the side, from beginning, from the temporal side. So in Denmark, most of the surgeons learn to do from up, from the 12 o'clock position, and then in refractive cases or the cases they may go temporal. But in the States, pretty much everyone is only going from the temporal. I think you guys do the same.
Yeah,
right?
we go temporal.
Yeah, only temporal. I think that's the best way actually. But
even those who sit at the top make their wound like. Yeah. Even if you're sitting at top, it's really temporal, isn't it? Because you're if you're right-handed.
And it is much easier, refractive outcome is better, and so on. But so in my cases, when I have cases where there's a complication and I feel time is critical, for a nucleus drop, I will just extend the wound and into the AC. But there's actually several studies from the Aravind Eye Hospital showing that you should rather convert to small incision cataract and do the small incision cataract because the risk for choroidal hemorrhage is much less. And usually if you have a complication already and you're opening up and making a big corneal incision, the risk for choroidal hemorrhage is bigger.
I think the biggest another advantage of doing the scleral tunnel when you're converting is less astigmatism post-op. I mean, you just But having said that, when you're having a complication, it can be it can be quite a nervous moment. It's not so easy to stay calm, especially if it's in a resident's hand. So it's also important to have that skill set already. So I wouldn't encourage it if you've never done a scleral tunnel before. But if you're comfortable doing scleral tunnels, it's definitely a good option.
And actually, I think it's a good idea to suture, as you mentioned already, to suture the scleral tunnel in the beginning. And also, if you are in a setup that are not used to scleral tunneling, you may risk for the next day the post-op the residents pressing the eyeball, pressure is 0, or something like that. So you need to be aware of all those cases.
Yeah. The good thing about putting one safety suture in a scleral tunnel is obviously you have a better sleep, but also you can bury the suture, close the conch over it, and you don't have to worry about removing it. Whereas ECCE sutures have to come out.
True.
They all have to come out at some point. All right. Very good. Thank you.
Thank you.